My name is Seminie Nyirenda. I'm the program manager for the Staying Alive project. Basically, we have an office here in Lilongwe and in Mangochi. Mangochi is our field office where all activities are being done. And this project, the goal is basically to reduce, to contribute towards a reduction of maternal mortality, which is the MGD 5A. And this project is being implemented in close collaboration with the Ministry of Health through the Reproductive Health Unit, as well as the District Health Office. Our strategies through which this project is being implemented include capacity building of healthcare workers, whereby we train healthcare workers in facilities and also those who are community-based, like health surveillance assistants, to ensure that they implement the activities or they provide the services in a high quality manner. And we also support the district in terms of improving access to family planning as well as postnatal care, but we also provide some drug supplies as well as equipment just to support them to ensure that their facilities are able to provide the quality of services according to the required standards. And also we support the district to improve the provision of BMOC services to patients, mothers, I should say mothers, who are seeking the services in health facilities. And we also have a component whereby we are supporting the district in the identification of obstetric complications, including fistula management. And this is like one of the core business of AMREF here in Malawi, whereby we have trained healthcare providers on how they can identify fistula patients, but also HSAs, who are playing quite a good role in identification of fistula patients. And after identification, these patients are referred to health facilities, and we have also trained some clinicians and nurses on fistula. These clinicians, they go to these health facilities to confirm if the patients that were identified by HSAs really have fistula. And then after confirmation, these patients are taken to a hospital where repairs are done. Initially, the repairs were done at Queen Elizabeth Central Hospital. So AMREF Africa would organize transport and logistics for the patients, going to Queen Elizabeth Central Hospital and then coming back. This was not quite sustainable. As a result, we discussed with the district, and we reached a resolution whereby now the fistula are being done at Monkey Bay Hospital. So since we started doing fistula repairs in Monkey Bay Hospital, we have managed to do the first camp we did 17, and then the second camp we did 28. Basically, in terms of fistula repairs, AMREF Africa, in coordination with the district and other partners like Reproductive Health Unit as well as UNFPA, we work together to ensure that the camp run quite smoothly. The last camp, we coordinated with the district health office. We engaged a surgeon from Queen Elizabeth Central Hospital who assisted us to actually do the operations, but also mentor other clinicians. And AMREF Africa initially supported 2 nurses and 2 ward nurses and 1 theatre nurse to do to attend a training on how to manage fistula at Queen's, including a clinician. And apart from that, we also sent 2 nurses from Monkey Bay to Fistula Foundation to learn how to manage fistula, just to build their capacity. So basically our role is to, in that way, we are empowering them to continue with their activities even when the project ends, they will continue. So we also used these trainedness to orient others that are based at Monkey Bay. So in that case, we are building the capacity of Monkey Bay to ensure that maybe after the project period, they should be able to carry out the fistula repairs. We also engage social welfare people to support them on how they can manage themselves, but also on doing some other activities like how to cook some donuts which they can sell, how to do the knitting. So we provide with the resources. So for us, our role basically is to provide technical support to the district to ensure that these people are provided with the necessary psychosocial support to ensure that they are well integrated back into their communities. As we are managing the camps, usually we also provide them with necessary drugs, supplies, as well as equipment. Like the last camp at Monkey Bay, we had to procure some beds. We procured 10 beds, 10 mattresses, and a variety of drugs. We also strengthen the linkage between the communities as well as the facilities. Previously, UNFPA was doing fistula repairs. So that's after some discussions, and then they understood our point, and then we reached an agreement, and they said, why not using Monkey Bay Hospital, because this is the hospital that they felt was being underutilized. There was a challenge in terms of space at the district hospital. So for us, we went together with the district team plus the fistula trained clinicians and theatre nurse to do an assessment at Monkey Bay, just to check if it was feasible to do the repairs at this hospital. They were quite positive to do the fistula camp at Monkey Bay, the staff at Monkey Bay. So then we started planning together, and then that's how we began to do the camps at Monkey Bay. So now they can manage more numbers of fistula patients as compared to those that they were sending at Queen's, because at Queen Elizabeth Central Hospital they were given like a portion or a quota that this time you have to send 20 patients or send 15 patients, whereas at Monkey Bay they can do as many as they can. So at Queen Elizabeth Central Hospital they were given a number because this is like a national camp. So each district is given a number, and these surgeons usually they were planning to do at least 100 surgeries, 100 repairs per camp. So usually they would take 20 from one district, maybe 15 from another, till they add up to 100. So they couldn't allow Mangochi to do more than they required. I remember during one of the camps, we had sent we identified about 50 something, and we bargained. We were told we should send 20. AMREF just started last year in 2030, but the impact that it has made in the district is quite big, as you have seen. A lot of women are benefiting from our services, and looking at our project period, it looks short, and it could be good if it could be like extended or having more years to work in the district, so that more and more women are repaired, because that's quite a significant achievement in terms of, let's say, a woman who has fistula and has recovered is quite something that is quite valuable. So it's my plea to our donors, AMREF Netherlands, if this support could continue and extend to other districts. because I believe that way more Malawians would benefit from that support. The sustainability of the activities that we are implementing now, AMREF Africa has worked with structures on the ground. We are working with CBOs, we are working with chiefs. This, we feel that with the continued training and supervision and mentorship, we believe that the project activities, the district will be able to continue implementing activities even after the project period.